So, for whatever reason, this week, Josh, a lot of the talk on TikTok has been about high blood pressure and hematocrit and what we can do to control them. So, since it's been such a hot topic for whatever reason, I figured let's talk about it, see what
Okay.
we can do.
I feel like that these questions come up fairly often, maybe not quite as much as in clomiphene, but you know, but it still comes up,
Yeah,
or anastrozole or estrogen blockers, where
correct. Which does come
it's
up pretty much.
yeah every day. Um, yeah, we could start with blood pressure. So, I mean, assuming and I say this too because there telehealth is obviously a very big delivery system of care nowadays, not just for like clinics like myself. I mean, we obviously do telehealth, um, but even regular health systems offer telehealth now too. It's kind of everywhere.
Hmm.
Thank you, COVID. Um,
Right.
and but I think what's happening is you have high blood pressure, and let's say you have somebody that's, I don't know, 40, 40, early 40s. Maybe they have a family doctor. Maybe they go, maybe they don't go, right? Full disclosure, I'll be 41 this year. I do not have a family doctor.
No?
I haven't been to the doctor ever. Do I check my blood pressure periodically? I do. But I don't have, do I check my blood work? I do. I check my own. Um, but I don't actually have a family doctor. So that aside, um, you know, you go, let's say you're like, I think I have low testosterone. Maybe you're listening to this podcast and you're going, you know what? TRT Dan and Josh are talking about these things. They resonate with me. I'm going to go check out a clinic, or maybe they call me. I don't know. And nobody, because it's online and they don't have a family doctor, or maybe they go very sporadically, nobody has checked this person's blood pressure. Right. And I can do a history and physical on somebody. And I need to know, like, hey, do you take any medications? Do you have any medical problems? We're going to go through like the whole gamut to kind of figure these things out. But I feel like a lot of clinics probably skip over a lot of that
Sure.
and don't really get into it. So you have a person that may have even had hypertension before they started testosterone, right? Because you can't check somebody's blood pressure over the phone. Um, and if they're not getting it checked from their family doctor, or they're not checking it themselves, which, it's hard to rely on people to do tasks like that, um, because they don't see a benefit in it. So they just don't do it. So compliance is really low and things like that. You're like, go pick up a blood pressure cuff and get it checked. And they're going to be like, okay. And then they're never going to go do it. Um, so they could have had high blood pressure before they started. And then they go on testosterone and they're like, oh, my blood pressure's high. Well, it may have been there before you even started. So that's out the gate. That's just, before we even get into like what testosterone is doing to your body or anything, it was a pre-existing thing that was there that just wasn't found until it needed to be found,
Right.
right?
So
Um,
just if we stop right there, if someone does have that, like say they come to you and they do have high blood pressure, is there something you do right off the bat, right from the beginning to deal with it or no?
so in my clinic, I manage blood pressures. I don't. I will, and the reason is I shouldn't say that I don't. I do, okay. But if let's just put it this way, if I had to manage everybody's blood pressure, I would basically be a family doctor.
Mhm.
Do you
Right.
know what I mean? And I'm
Yeah.
not. I'm a specialist, so I don't want to manage everybody's blood pressure. So it's not. I don't have that in like my role, because if I did, then it would make me like, where do you got to draw the line somewhere,
Hmm.
right? So I'm going to identify it, but then I'm going to be like, you need to get this under control. And I might gatekeep it and be like, if you do not get your blood pressure under control from your family doctor whatsoever, then I can't have you as a patient here.
Okay.
Do you know what I
Okay.
mean?
Right. Right.
Like that type of stuff. So these are some things, where we want to involve these other people. We want to take the appropriate thing. Uh, can I manage blood pressure? I can. Yeah. If I have somebody that comes in and they're normal tensive, okay, their blood pressure's fine, and they come back and it's elevated, Depending on how elevated it is, right? If somebody starts out and they're like 120 over 80 and they come back and it's like 135 over like 90, I'm not going to do anything. I'm not going to treat that blood pressure. I'm just going to ride it out because more than likely it's going to come back down like in like 3, 4, 5 months. Not
Is
worried
that what
about it.
typically happens though? Is that in the beginning when you start, it will
Yes.
raise? Okay.
It's very, we do see a transient increase in blood pressure in several, a good percentage of our patients to start. Usually it can be upwards of 10 to 15 millimeters of mercury on your systolic, so your top number. And I've even seen it on the bottom, not quite that much on the bottom number as well. But I'd say that's on average. And I don't have data for that. That's just in my clinic. That is what I have noticed. Okay.
Okay.
Um, but yes, testosterone can increase your blood pressure. Okay. The matter of fact, the FDA just removed the cardiovascular risk sticker and slapped a nice old hypertension sticker on at the same time. So they took one and slapped one on, and
Sure.
that happened in April. So yes, testosterone can cause you to be hypertensive. Okay, um, and sometimes it doesn't even necessarily matter if you're fat or not. Essentially, I have very guys with normal BMIs that have high blood pressure. So, and blood pressure in of itself is usually a combination of things, not just like one thing. Okay. Um, so can I manage this? So let's say I have somebody, he's normal tensive when he comes in and he's mildly hypertensive after his first visit, maybe even towards his second one. I'm going to keep an eye on it, and usually it gets better, right? As the some of the reasons that cause hypertension, which we'll talk about later on, start to sort of dissipate after time. And two, if somebody's making some body composition changes, they're doing resistance training, they're eating better, they're making these changes, blood pressure starts to change because of those things changing too.
Okay.
Okay.
Yeah. Well, that
So
makes sense.
generally in a positive way. Okay. So if they're using testosterone as a tool, like they're supposed to, then generally they can improve those metrics on their own. And we don't need to intervene. I don't need to put somebody on a medication. Okay. Um, if let's say they come back and it's moderately elevated. Maybe it's like 150 or 160, and they have never been there. And like, wow, my blood pressure is really high. We may do like a repeat check of it in a couple weeks, and we may have them come back in. I may say, hey, you might want to go see your family doctor. But in that particular patient, depending on what that is, I may end up just treating it myself. I don't always do that. But if we do treat it, I typically use an angiotensin receptor blocker. So losartan, telmisartan, like that family of drugs,
Hmm.
because it interacts with the ROS cycle, which we can also talk about. But um, those are drugs that I like for that. You can also use an ACE inhibitor, which is also in the ROS cycle in terms of blood pressure inhibition. But oftentimes, you see people on beta blockers or calcium channel blockers, like Norvasc calcium channel blocker. Beta blockers are like metoprolol or nebivolol or anything that ends in lol, essentially, is a beta blocker. Those should not be used in this case. Those are going to be their mechanisms a little bit different than what we need to focus on, and that's why I like ACE ARBs number one, and maybe ACEs is number two. And to a lesser extent, you could even consider mild diuretics like a thiazide diuretic, but I don't like to introduce those because they end up making people urinate a lot, and then they get annoyed, and this, that, and the other.
So,
Um,
but Josh, if you were to prescribe those medications, is that a medication that you take for is like the rest of the time or is it just until
no,
you?
yeah. So if I'm doing it transiently with the intent that we're eventually hopefully going to remove it.
Okay.
Okay. So that's why, like, some people I will, because, like, let's say they're motivated and they're like, I've started going to the gym and I'm this, that, and the other. I just need to get them over the hump.
Mm,
You know what I mean? And if they can get themselves over the hump, we're going to yank it. But if I got
okay.
people that are like, I'm not doing that, then that's where I'm like, I don't really want, like, you need more management than what I'm willing to kind of
Okay.
put in here
More of like a
and do that.
long-term thing.
More of a, yeah. And it's not to say that they can't come off of it too. They more likely can if they start making these changes. But when those changes happen isn't obviously in like the next
Okay.
foreseeable like 6 months or
So
something, you know.
the medication that the way you're prescribing is like that. It's just like a little boost to get
it's
us
it's
over,
it's a
get you going.
transient management as we progress generally in the first 3 to 9 months of therapy, and then
Okay.
after that we typically don't necessarily need it, we can start weaning it off, assuming this patient is making some healthy changes in their life. And they do. We talk about that pretty heavily at our
Yeah.
meetings. And
Hmm.
that's really the only way I kind of intervene in that aspect. If not, then I'm just like, you need to see your family doctor for more chronic management of this. So,
Okay.
um, but that's kind of blood pressure in a nutshell on how it happens. But yes, it is very common. There are several factors as to why your blood pressure may go up. And, in relation to testosterone, there's going to be potentially some fluid retention, and that's activated through the ROS cycle. So ROS is what I'm talking about is RAAS, and that's renin angiotensin aldosterone system. You've heard me talk about aldosterone or aldosterone before. That is a steroid also. It's a mineral corticoid, I believe, or glucocorticoid. Here I'm figuring out my oh, figuring out my steroid hormones here. But it's made by the adrenal gland um, in the cortex, not the medulla, and it promotes sodium retention in the distal nephron of the kidney. And if you, okay, in layman's terms, sorry to get all technical. Basically, what happens is you have the nephron is your functional unit of your kidney. It's how it makes ion exchanges. So blood goes into your kidney, enters the nephron, and you have ion exchanges. When I'm talking about ion exchanges, if we get into chemistry, we're things are talking about cations and anions. So things are positively charged and things are negatively charged. And there's going to exchange there. And with those exchanges, fluid also shifts with these exchanges. So if sodium kicks out, sodium also goes out because wherever sodium goes, fluid goes. Okay. If we kick it, but then reabsorb it, guess what? We also reabsorb fluid, and then that comes back in, and that increased fluid or increased vascular volume can increase our blood pressure. Okay.
Okay.
So that's one mechanism that you can see from that. There's also endothelial dysfunction that can happen. Now, testosterone will improve um, the endothelium over time. And that's what causes vessels to kind of dilate and constrict. Okay, so there can be some changes in that when we're introducing testosterone. Uh, so there's that. Um, the hemoglobin and hematocrit that increases can increase intravascular shear forces because it does become there's more red blood cells in a space, and the viscosity does increase. And if the viscosity increases, the pressure to push it through also increases. So
Sure.
therefore blood pressure can raise from hemoglobin and hematocrit.
Right.
Okay. So those are some things to think about as to why that happens. um,
But Josh, you know what? Is there some people that just have high blood pressure, even if they're
yeah.
in great shape? Like what? I mean, they're just genetics or whatever it may
Yeah,
be.
so you could have what's called idiopathic hypertension. It's rare, to have just high blood pressure for no reason, but yeah, it does exist. Okay,
Okay.
so it's a thing, um, and generally you're going to have that figured out probably before you know
Right. Sure.
you show up at my doorstep.
Yeah.
But yeah, there's definitely ways to manage blood pressure, but ultimately, what you should be doing to help mitigate some of the blood pressure issues, should you be having them, is one, you should be working out. Like exercise is going to be key to help keeping your blood pressure low, right? Two, your diet should be good. So just like anything else, we always talk about, diet, exercise, or diet, nutrition, or nutrition, exercise, and then TRT gets on board there. It's the same thing for this stuff too. Um, Having your diet good, having your nutrition on point, and having good exercise is going to be key to helping keep your blood pressure low. Dietary sodium, obviously, if we're retaining, we don't want to eat more of it
Right. Sure.
because
Yep.
or excess. I'm not saying not to eat salt. You definitely will need it. It's an essential electrolyte that you need, but you know, you don't want to have too much of it, because if you do, you're going to hold fluid. Like when I worked in the emergency room years ago, we'd always you'd see a ton of patients come in the ER with heart failure or uh, pulmonary hypertension, or oh shoot, what's the word I'm looking for? Uh, they get fluid in their lungs, essentially. Um, The term's escaping me. I know what it is. It's been a long day.
Right. Well, that
The
happens.
math ain't mathing in my brain right
It
now.
happens.
Anyway, at any rate, pulmonary edema. Oh, there it was. Okay. And that's because these people end up getting in a fluid overload because they eat ham for like Thanksgiving or whatever. And then it never failed. Like a day after like Christmas, major holiday, you got people coming in with like blood pressures through the roof and their legs are swollen like crazy and they can't breathe because their lungs are all backed up with fluid because they wanted to eat that ham.
Just from
And
salted meats?
yep.
Like that's no shit.
Yeah, dude, it was, but these people have bad hearts and stuff anyway. So
Oh.
they're stressing an already taxed system.
Hmm.
Okay. But every holiday, it was like without question, you'd get at least 5 patients in that ER that were like puffer fish
Jesus, really?
just from eating ham.
Damn. That's
Ham
crazy.
and gravy, dude. Gravy's loaded with salt.
Oh, so like after Thanksgiving,
Yep. I mean,
people,
just that's what I'm saying. They just eat all this salt and then they don't do
mm,
anything. They just loaf around, and they just swell up like a balloon. And they would come
Jesus.
in and heart failure and all puffy, and it's because they ate too much salt. So um, we have to support their systems and hopefully get out. But they already have heart failure, and that's like when you have a bad heart, that the cardiologist is like, don't eat a ton of salt. Why? Because when you eat salt, you have to drink fluid to cause that balance in your body, right? If you have too much salt in your serum, it's going to pull fluid from your intracellular space to the extracellular space. Okay.
Right.
To help cause the equilibrium. Your body's
Right.
always going to try to
Balance.
be equal and balanced between the two spaces,
Sure.
right? So then it pulls all this fluid out. So your cells shrivel up. Okay. But your extravascular space outside the cell is like busting at the seams. So then you get like all this puffiness, your feet get fat, and it's because you
Damn.
had all this salt. Do you ever know, like, even if you eat, how like your feet feel tight? You know what I mean?
I've never
Never had
had,
that? You get like
no,
sausage fingers sometimes,
no.
when you eat too much
I mean,
salt.
here's the thing, dude. I sweat like a pig at work. So like, it's, you know what I mean? Like today, it was like 104 degrees. It said it felt like, and we
Yeah.
were just saturated. So I even drink Element. Like I
Yeah.
add salt to my water.
Well, you're in a different, but
That's
I'm
what I'm
just talking
saying.
about
So
like
for
general,
me,
like post holiday, or you're eating in Thanksgiving and you're like, man, my fingers, like my rings don't fit really well. You ever hear people say that?
yes,
Like my rings
yes,
are too tight. That's because they're holding on to fluid and they're
yeah.
swelling up, probably because they ate too much salt. Okay.
Damn.
So that's what happens. And if you have somebody that can't move things around their body very well because their heart's not very good,
Hmm.
then it backs up. They get venous congestion and they swell up. So, if we have more aldosterone circulating from the testosterone, we're holding on to more sodium. The last thing we want to do is eat a shit ton of sodium. Okay.
Okay.
This is typically a transient response that we do see patients have within like the first 6 months. Okay. Um, this is me dealing with patients in my clinic.
Hmm.
But we do see that. Sometimes it can linger a little bit longer. Again, it depends on the comorbidities and the health of the patient and how motivated they are to actually make some of these changes earlier on. But those are the blood pressure medications we may need to use, or that I may suggest that they talk with their family doctor about, to kind of help get those things managed, because we do not want to have hypertension for a prolonged period of time, and cause some vascular damage or stress somebody, because that's another thing. If I get a guy in his 50s in, I can go through his health history, but like I don't know what type, I don't know how hard of a life he's lived, essentially,
Right.
right?
Prior to that.
Maybe he was, he could tell me he was a smoker, and I can say like, well, how much did you smoke? Well, I quit, 5 years ago, but prior to that, I was ripping 2 packs a day. Like,
Right. Right. Yeah.
so like there's I don't know
Mm.
this guy's vascular status, essentially. So these are things we have to be careful with. Um,
When Josh, when working out, would it be both cardio and muscle training?
When I initially tell guys to start working out, I don't tell them to focus on cardio
Okay.
initially.
Just,
I want them to bring cardio in eventually,
hmm.
but I want them to just initially just start with resistance training. That's
Okay.
going to be the best thing for them with testosterone on board out the gate. Doesn't mean that I don't want cardio. I do eventually, but just to get started, just go pick up some heavy shit, you
Hmm.
know, and make it worth your while. Make your muscles hurt. You want to wake up sore the next day. You know what I mean? That's how you know you did a good job, and things are doing, and just keep doing that. Minimum 2 days a week. If you can put in 3, that's even better. But you don't have to go every day, especially when you're first starting. Even if you're a veteran, you don't have to go every day. You can make plenty of gains working out 2 to 3 days a week.
Sure.
Easy.
Yeah.
Um, so don't overtrain yourself either. But yeah, I mean, and once you start making those changes and your diet gets better, your body changes with it. It doesn't change overnight, but it
Hmm.
changes. So,
Yeah.
um, but yeah, you definitely want to, keep your blood pressure in check. Keep an eye on it. It definitely can elevate from testosterone. It definitely will elevate for all the guys that are out there doing all the synthetic androgens. So they really have to watch.
Mm.
So, you know,
Yeah. You know what? I was just going to ask, what about if you add, like if guys are on TRT and say they add a peptide or something, will that do
um,
anything?
peptides in general don't, not a lot of them are going to really influence your blood pressure directly.
Okay.
They can have some indirect effects, like for example, like the growth hormone secretagogue can cause fluid retention, and
Mm.
that fluid retention can contribute to higher blood pressure values. So those are things that you should be aware of, so that so it's not directly causing it, like it's not constricting your vessels or anything, but um, at least the more common ones that are coming to my mind that we more frequently use. I'm sure there's maybe some kind of crazy obscure ones that people are
Yeah, I'm
doing that
sure.
we use a lot of, we have growth hormone secretagogues that we do use in patients. We obviously have GLPs that we use periodically as well. Um, and then obviously like TB500, BPC157 peptide wise. Might be prescribing bremelanotide sub Q this week or next week. So that one, I haven't prescribed that one sub Q yet for anybody, but that one's for libido.
Mm.
So we might see how that one fares out with somebody. But yeah, none of those should directly increase your
Okay.
blood pressure from
Okay.
just taking it. But the effects that they can cause on the body could potentially transiently cause it too.
So guys that are in shape and on TRT, um, could anything be like maybe their protocol? Like, because I mean, some of these guys that do say they have high blood pressure, I mean, I look at and they look like they're not like, they look like they're in shape.
Right.
So, I mean, would adjusting their protocol, you think, help at all? Or,
Possibly. The other thing too is like a lifestyle evaluation. Like I know a lot of people drink a lot of caffeine and it kind of
mm,
flies under the radar. I actually had a guy. So this is a great story. This is a good teaching moment. Patient in our clinic, super nice guy, jacked. This dude's a specimen. Like looks great. Um, doesn't use synthetic androgens, nothing like that. He's just a very disciplined individual, and he's just a very former military. So I mean, like he's put together very well. Okay. Um, he comes to us. He's on TRT. He has a pretty extensive medical history that have some really weird things that we have to be very careful about. Stuff that you're probably just not going to see anywhere. Um, and one of them is he has, it's called JAK2 malformation or JAK2 gene issue, but basically his hemoglobin hematocrit's always high, always,
mm,
even like not on TRT. He has to donate blood. So unfortunately, we can't get away with that with him. He has to, no matter what. Um, so when I started with him, with TRT, where I'm like, we're gonna go very light because like we're already like up here, and he's hypogonadal, so like I want to help him, but at the same time, I'm like, I don't know what's going to happen with the proliferation of your hemoglobin hematocrit. We talk about it, and he lives a pretty regular guy life, drinks beer on occasion, with his buddies, and
mm-hmm,
does this. He's very active. He's in great shape. His diet's pretty decent. His blood pressure was fine. At least during our evaluation, we take a vital signs on everybody that comes in our door prior to doing our visit. Even on your follow up, everybody that comes in, every time you come in, you get a blood pressure, heart rate, pulse ox, just like
yeah,
you're at the doctor's
yeah.
office. Okay. And I get a call 3 months into it. He had a stroke.
He had a stroke?
Yeah. And I'm like, okay. From anyway, we go through all of it. And it wasn't like a stroke that caused any deficit. It was a ischemic stroke. So there's hemorrhagic and there's ischemic. So hemorrhagic is going to be like a bleed that causes a stroke, and ischemic is going to be some type of either severe constriction or like a blood clot. Okay, that blocks flow of blood into a place.
Mm-hmm.
Therefore, it becomes ischemic. Doesn't get blood, doesn't oxygenate, tissue starts to die. Okay. Come to find out, so after seeing cardiology, neurology, the whole 9 yards, what ended up being the culprit is this guy was drinking almost. He was drinking like 800 to 1,000 milligrams of caffeine a day.
1,000
Yeah, a day.
milligrams?
Yeah.
1,000.
It was like 3 scoops of pre-workout. Like it
Holy
at once,
shit.
not like, oh, I had 200 and then 2 hours later I had 200 and then, 5 hours later I had 200. It was like, bam.
Holy shit. Aren't you supposed to have like 400 a day or something?
400, less than 400 a day is like,
So 400, yeah, less than 400.
yeah.
This
And
dude
we
was
were
at
like,
1,000.
yeah, it was intense. And I was like, I think that's probably what caused your stroke.
How
And
the fuck
his
did he
neurologist did
sleep?
too. He was using it to just get through his day. I think that's kind of how terrible he was with his symptoms.
Oh
That
my
and
God.
he doesn't. And the crazy thing is, he still drinks caffeine now. But like, I was like, no more. So I actually took him off testosterone because at the request of one, him and his family, not because they didn't want to do it, but because they were trying to figure out everything.
Get their feet underneath them and get,
Correct.
yeah.
Exactly. So I was like, that is totally fine. I'm 100% okay with that. I'm like, I don't think it was a testosterone. I can tell you right now, it wasn't testosterone. There's no way. Um, and his neurologist and cardiologist also agreed. They were like, yeah, no, that's definitely not what it's from, which I was very thankful for, that they were very cool
Yeah,
about,
didn't throw you under the bus.
right. Cause everybody's always like, it's the testosterone that caused it, and they were real chill about it. They were real cool about it. And yeah, after all said and done, that ended up being what the issue
A
was. He had
thousand
ischemic.
milligrams.
Yeah, because caffeine's is a vasoconstrictor,
Holy shit.
right? So it clamps down on your vasculature, and then no blood can get through. So, I mean, I've seen people like in the hospital, for example, when I worked in PACU, we would have to do like, they'd have to cut people's limbs off because of vascular disease. So, like if somebody has like a dead foot, this is like when people have diabetic foot ulcers, we'll say that. Okay.
Yeah.
The reason diabetic foot ulcers, like they end up losing their foot sometimes, is because the vasculature leading to the ulcer itself is like toast. It
Mm.
doesn't get good blood flow. And if we don't get good blood flow to the area, it can't heal, because your blood has to carry all of the
Right.
oxygen
Yeah.
and all the nutrients for your body to this
Sure.
area to create it to heal. And if it can't get there efficiently, it
Hmm.
can't heal it. So what ends up happening is these people that are diabetic they have neuropathy in their feet. They can't fucking feel anything. They bump it on something. It causes a cut to come open. They didn't even realize they did it, and when they finally realize they did it, like they're like, look down and they're like, they got this gash on their foot and they're like, oh shit. And they could have even been there for like a whole day. Who knows? And the next thing you know, like it gets infected, and then they get put on
Jesus.
antibiotics, and sometimes they work something out because it's not being perfused very well. So the antibiotics that you take systemically can't even get there.
Holy shit.
And then, or maybe it does, or maybe it just slowly like just spreads a little bit, or maybe it gets slightly
Right.
better, but then it doesn't. And next thing you know, it's just like their vasculature to that area is so poor. They're like, and the infection spreads, and then it gets into their bone, and then they get osteonecrosis and
Jesus.
osteomyelitis. And then they're like, yeah, the only thing we can do now is just take your foot. And they have
Yeah.
to take it back to a place where there's good vasculature.
Right.
Like you can't just like, oh, I'm just going to cut this area out. Like, yeah,
Yeah.
they're
Gotta
like, we're
take
just going
it.
to take it to where
Sure.
the next big artery is, essentially, because
Jesus.
everything to there is just hosed. Um,
God.
yeah, so I've seen that happen, obviously. But yeah, so too much, and these are people, not just from diabetes, but chronic smokers, people that smoke for years and years and years and years get vascular disease because it clamps down on causes all this clamp down on your vessel. And then you have no compliance, right? Those vessels don't constrict and move. They're like rigid and in place and permanently like constricted. And then it's like putting your finger over a garden hose. Like what happens when you put your finger? It
Right.
shoots
Yeah,
out, right?
exactly. Yeah.
Now we're trying to shove the same amount of blood through like this
Mm-hmm.
tiny space, and it doesn't get any bigger. It's like permanently fixed in place.
Mm.
So these people have higher pressures because of that. So these people can also have high blood pressure. It's more of a peripheral issue, but it can cause blood pressure issues because of that. So any type of constriction, so doing a good lifestyle evaluation sometimes can be like that simple. We often overlook it, but here, come to find out, literally that guy that had a stroke, that was caffeine induced, just
Holy
because we're
shit.
crushing caffeine.
How the hell did somebody sleep? How did he sleep at night?
Dude, I don't know.
Dude,
I'm
if I
just telling
had,
you.
I think the most I've ever had was like 600 and I was out of my mind.
Yep.
Like 1,000.
Yeah, 800 to 1,000 milligrams of caffeine a day.
Holy shit.
Yep.
And he was taking like the majority of it just basically at one time, like three
I
scoops
would
of
say, yeah,
pre-workout.
exactly.
What the fuck? How did he not have a heart attack while he was
Well, I think he
lifting?
was so used to it because he had been doing it like in higher volumes for quite
Yeah.
some time that it just finally caught up. But
Damn.
you gotta be careful with that stuff. It
Yeah.
does it seems so innocuous, right? Like it's not going to harm you, and literally that can be what happens.
Yeah, I
So,
mean, think like if your heart's already beating because of the caffeine and it
mhm,
like an extreme amount, and then you're, lifting, but imagine lifting heavy weights. So you're just, compounding it. You know what I mean? It's like,
right,
Jesus Christ, that's like a disaster waiting to happen.
right. So, I mean, can you be in good shape and still have high blood pressure? It is possible, and if that's
Mm,
the case, then yeah, you probably should get that taken care of because the last thing you want to do is have problems with your pressure. But also, again, lifestyle modification. Are you drinking a lot of caffeine? Do you have a lot of stimulants on board? Right? Nicotine pouches. Right? We always talk
hmm.
about the Zins in the Rogue. They cause vasoconstriction. So,
Yeah.
these are things you got to just be aware of. And it's not just, well, hey, maybe I pop a bunch of Zyn pouches in and have pre workout. Right? So now we're like double loading it.
Right. Dry
Okay.
scooping where, yeah.
Right. So these are just things you kind of have to be sort of aware of. So if we're saying, well, I may have high blood pressure and I'm in really good shape, but is it being caused by something else too?
Mm,
So
okay. Well, that's good. Well, at least I think everyone's got an idea now. We can start. Okay, so it's a big picture. We got to start taking
it's
pieces
a
off
big
the puzzle.
picture. Yep, it's a big picture. There's it's not like a simple, cut and dry answer for most people.
Yeah.
But it's definitely something that you should, keep an eye on, and we do with all of our patients. Obviously, we check all their blood pressures and try to make sure that they're managed and get that taken care of. And so we've had people leave like our clinic because they don't want to go on a blood pressure medication. They think the
Mm,
testosterone caused it. But the funny thing is I've actually had two patients recently come back and they're like, testosterone is causing me high blood pressure. I'm like, I don't really think it is. Um, you know, uh, and then they come off and they still have high blood pressure.
right. Well, yeah.
It's just like,
I mean,
okay.
in your, does it seem that majority as time goes on, their blood pressure gets better?
It does,
Is that
yes.
okay?
I do see that. I
That's
do
pretty
see that.
common.
And two, testosterone long term, we're gonna have less visceral fat, we're gonna have better cholesterol metrics
Hmm.
long term. So, we check a cholesterol at everybody's yearly follow-up. We'll check a cholesterol, we'll check a lipid panel. And I'm not ultra aggressive on getting after people for their lipids because um, you know, like if you have an LDL that's 120 or something, I'm gonna be like, okay, like fine, your triglycerides are fine, you're fine. Like I'm not going to say you need to go talk to somebody about a statin or whatever, but if your lipids are just completely bombed and torched, then yeah, we may have to talk about that. But um, for the most part, a little mild elevation in one of those categories, I don't get too worked up about,
Yeah.
because it's easily a fixable metric. Now we've brought awareness to it, and we're going to work towards the goal, but we're
Right.
going to try and do it without pharmacological intervention and just
Sure.
maybe some diet, maybe
Change the
maybe
diet. Yeah.
maybe supplement,
Hmm.
certain supplements you can use to do for certain things,
Oh, Josh,
in
is
that
there
in
any
that range.
supplements for blood pressure that help with blood pressure?
For actual blood pressure,
Just to help lower it? Is there?
hemoflow, obviously.
Shit, I walked right into that one.
You did walk there.
Fuck. Yeah.
No, not really.
Nothing.
I mean, you have to have something that modulates one of the systems that's going to cause that. You need to either modulate the endothelium, or you need to modulate the Ross cycle of some form, or the heart rate, or calcium channels,
Mm.
in order to change it. So, supplement wise, um, Nothing that's going to magically change your blood pressure and make it healthy. Diet, exercise, time, yes, absolutely.
Okay.
Supplement wise, nothing. There's no quick fix for that.
Hard work. What
Hard
it's
work.
going to be.
It's always going to be hard work. Everybody wants
Yeah.
that magic bullet. It
That's
doesn't
what it
exist.
seems to be. It seems it
Yeah.
just seems like everything comes down to the same, pretty much same answer.
Yeah. I mean, don't get me wrong. I'd love to sit down and eat cake all day, but
Yeah.
it's easy, right? It's easy. It tastes good. It's enjoyable, but like,
Sure.
you don't gain anything out of it. You end up, it's great while you do it, but then you gotta pay the consequence. You gotta pay the
Hmm.
price for it. So
Yeah.
if, it's like
Sucks.
anything else, it's sometimes doing this work, it sucks. But then guess what? You get all the good out of it.
Yeah, exactly. Yeah.
You get the reward
Yeah.
when you
Well, I mean,
finally get there.
I mean, listen, you eat something that you enjoy, or that's, cake or a cheesesteak in my, where we live, and ice
Right.
cream, whatever it may be. Like after you eat it, you don't feel the same way like when you just got done working out.
No,
You know what I mean? Like
absolutely
after
not.
you're done eating, you feel like, oh God, I feel terrible.
Yep.
And when you're
It
done
felt great
working out,
eating it, but
right?
then
Yeah.
then
And then the
where
next
the
hour, you're
workout's
like,
opposite. It sucks while you
correct.
do it, but it feels good afterwards. Yeah.
Exactly.
Yeah.
Afterwards, you're like, oh, thank God.
Yep.
But well, I mean, I guess that's pretty much explains how we can control that.
Yep.
The next one and the big one is the hematocrit. I mean,
Oh boy.
you know how that goes. I think everyone at some point has or everyone knows somebody who donates blood every 3 months,
Yeah.
or I don't know.
Did we do a podcast before on hematocrit?
Yes, that was like in the early ones. We did um, hemoglobin, hematocrit, and wasn't it in like the first five? I think we
I
did.
want to say it was.
Yeah,
So
it
I think
definitely was.
I think I'm gonna tell everybody at this point to go listen to that one because it's good, and has a lot of information on it. So if you really want to have that answered, do that. I will touch on a few extra things. Um, one,
Episode number 3.
yeah. So there you go. Like we have a whole episode dedicated to that.
Yep.
Um, but I will say I'll touch on it briefly here because since we have a whole nother episode, there's no use doing two episodes on kind of the same thing. Um, hematocrit is the percentage of your cells that we're going to measure. Hang on one second. Hemoglobin hematocrit. So it's a proportion of red blood cells in your blood. It's your hematocrit. Okay.
Hmm.
Um, you're going to have a ratio of what we want that to be. Different labs have different ratios because different labs achieve their hematocrit ratings from a few different things. So, for example, the lab I use does not use the hemoglobin to calculate the hematocrit, which is typically what LabCorp would use. Even though I use LabCorp for, so if you're a telehealth patient, yes, we do use LabCorp. Yes, it will be done their way. If you come in for blood work in my office, it's a different lab. That we send everything to, and they calculate hematocrit based off your mean corpuscular volume, okay, or your MCV.
Is there a difference like that where you get a different?
Yeah, so the MCV, you're going to get a much higher reading in your hematocrit. So, like for example, if
Huh.
LabCorp cuts your hematocrit off at 51 and they say that that's high, my lab cuts hematocrit off at 56.
Oh, okay.
Okay, because it uses a different measurement, a different reading. So
Hmm.
that's just the way it's done. You could still extrapolate some values, meaning like I could still theoretically, uh, a typical hematocrit is about 3 times of that of your hemoglobin. So if you take your hemoglobin and multiply it by 3, that's
Hmm.
roughly your hematocrit. Okay.
Okay.
So if you have a hematocrit of 15, then or hemoglobin of 15, then your hematocrit should be 45.
Right. Okay.
Roughly. Okay. That's a quick and dirty way to figure it out. That's been the traditional way
Huh.
to do that. But if it's calculated off your mean corpuscular volume, your hematocrit will be higher if your mean corpuscular volume is higher. What is
Okay.
mean corpuscular volume? That is the size of your cell. Okay. That is how big those cells are. If they're bigger, typically we have less of them. If they're smaller, typically we have more of them.
Hmm.
Okay. So those are some things to think about. To And that's getting into a whole lecture on anemias and everything, and that can get deep really quick. And I am not a hematologist. I mean, I do obviously know about microcytic, normocytic, macrocytic anemias to a degree, but I can't sit here and talk indefinitely about them. That's a little bit out of my pay
Yeah.
grade for a lot of that specifics in that aspect. So I won't pretend that I'm an expert in that because I am not. But I know enough to be, smart enough to recognize things. So
Yeah.
I'll say that. And obviously, I know plenty within our realm that we deal with. So hemoglobin hematocrit, it's definitely going to increase in about 90% of people that go on TRT. I have had people that go on TRT and their hemoglobin hematocrit doesn't really go up hardly at all, barely moves.
Hmm.
So that happens. I would say on average, hematocrit goes up about 10. Hemoglobin hematocrit goes up about 10%.
Okay.
Okay. So if you started at 15 and 45, then we can expect you to come back around, 16 and 50,
Right. Okay.
at worst. I would say it's between 5 and 10% on average, 10% probably on the high end. Okay.
Okay.
Of increase. So keep that in mind. So when I'm doing an assessment on somebody when they come in, and let's say we're using lab course hemoglobin hematocrit scale, and their hematocrit's 50.5, and I have not started them on testosterone yet, I'm going to ask myself, why is this person's hematocrit so high, towards the high end of normal, or almost cresting over before we've even started? So these are things that often get passed up. So why does this person have a high hematocrit? Were they severely dehydrated? Do they have some type of lung disease? Do they have sleep apnea? Do they have, some type of underlying condition that we don't know about? That we need to talk about. Do they have PCV, which is polycythemia vera? Which is generally going to also reflect on some labs too. They're going to have multiple other labs that are high as well, platelets specifically. And so these are the things you have to think about. So you have to be cautious if you have somebody that, has a high hematocrit or higher-ish hematocrit before you start testosterone. We know that's going to push them over, quote, the normal range. When do I start to worry about hematocrit? I generally don't worry about it too much. I do have some people that have come back fairly high, and I do not like recommending blood donations because the thing with the blood donation is we're not fixing the root cause.
Right. Yes.
Okay.
Yeah.
Because if I have somebody and I have them go donate blood and they go give blood and it drops their hemoglobin hematocrit, we also dump ferritin, which, if we do it once, we're probably okay. Testosterone is going to eat up some of that ferritin too, because you use ferritin to make red blood cells.
Hmm.
So it's going to eat up some of that ferritin. So they may have like lower ish ferritin, and then go donate blood, and then they lose even more of it. And then they're like, I feel tired all the time. Yeah, it's because you just gave all your ferritin away. At any rate, I don't have a problem if people donate blood like once every 6 months. I get some people that like to do it just because they like to do it, and I say don't donate any more than once every 6 months
Okay.
if you can. And that's just kind of a general rule of thumb. Like, still allows you to be generous twice a year, but then it generally doesn't impact how you feel when you're on testosterone, and you can get the best of both worlds essentially.
Okay.
But if I have somebody, if somebody's going to donate because they have a high hemoglobin hematocrit, let's say their hematocrit comes back and you're on lab course scale and it's like 56, 57, and they're like, whoa, hold your horses there, bucko. That's way too high. And you have a provider that's, maybe not up to it. And you go give blood and you come back and your hemoglobin, they get you to 50, right? Take off, two bags. So a bag's usually anywhere from 300 to 350 cc's. So they take that off. They take off 600 mLs of blood, and they get your crit down to 50. And then 3 months later, you're back at 57.
Right.
And what are
Exactly.
they going to tell you to do? They're
Right.
going
Just
to go tell you to donate again.
right. You just keep
And then
rinse and
and then we're in
repeat.
this perpetual state of donation. And instead of doing that, why are we not trying to figure out why we continue to have this high hematocrit?
Right.
Right? Do I have sleep apnea that's just undiagnosed and is going unfettered, and I
Hmm.
am hypoxic at night, and therefore I'm not oxygenating well, and my body's creating more red blood cells because I don't have the oxygen I need. So it's responses. I need to make more red blood cells to hold on to the oxygen that I do have or that I can
Yeah.
get, because I'm having periods where it's not there. I mean, why do you think the Olympic Training Center is in Denver? It's at
Exactly.
it's at altitude.
Right.
And it's at altitude. And yes, the oxygen percent doesn't change anywhere in the atmosphere. It's 21%, 20,000 feet versus, sea level, but the pressure is different. And the pressure lowers as you go up, as you lose atmospheres. And when we're at sea level, when we breathe in, you have that one atmospheric pressure that forces oxygen inside the alveoli in your lungs, and that gets it into the blood. As we go up in altitude, that is no longer one atmosphere pressure. And when you breathe in, that same pressure does not exert the same force, and it cannot push the same amount of oxygen into your blood. So your body's compensation for this, because it's not getting the same amount of oxygen than it was at sea level, is to say, yo, kidneys, I need erythropoietin. Let's make some more red blood cells. And then boom, you start making more red blood cells. They go up. And the more red blood cells you have them because it needs to be able to carry more oxygen
Sure.
that you're not getting from the pressure decrease.
Hmm.
Okay. So this is another thing to consider too. Like, where do you live?
Right.
Okay, so
Exactly.
if I'm
Yeah.
if I'm looking at somebody's baseline
Hmm.
labs, and I'm doing telehealth, we do Nevada, on there, and that's not a particularly mountainous area, but it has areas that are mountainous. Um, so is that something that's there? Or Colorado or Utah or California or any of these places that have higher elevations where people may live for a period of time,
Yeah.
they're going to have a higher hemoglobin hematocrit just because they live at elevation.
Hmm.
Okay. So, that's going to be their baseline. And I think people forget that too. If I go from having somebody who's, 48 hematocrit and then, now they're 53, and some people are going to be like, oh, that's a little too high. You're over the normal range to go donate. No, you're going to be fine. Like,
Right.
people in
Right.
Denver walking around 53, 54 hematocrits all the time.
All. Yeah.
So,
Exactly. Every day.
and they're not dropping over dead. So,
Right. So I mean, what would be some of the ways to lower it? Um, I mean, obviously, I mean, mine lowered when I switched to 3 injections
yeah.
like
So,
that.
you're going to have a dose dependent response for red blood cells. Basically, if we give you a lot of androgen at once, you will make more red blood cells,
Okay.
um, because we just blasted you with a ton
So you just get
of
like a huge
androgen.
spike of everything in your.
Yeah, because that testosterone is going to cause that stimulation effect for erythropoietin, and so EPO
Mm,
is the what we call that, and you're going to make a lot more red blood cells. Versus if we give you less testosterone per injection, but span it out a little bit more, we
mm,
don't get quite the effects we have as if we just blasted it, with
okay.
a high amount. Um, so that's why I do like to do that. Also, the study of what was it, test sip IM versus test enanthate sub Q showed that the sub Q route decreased um, hematocrit. Um, and again, I think this has to do with the rate at which it's absorbed into your body.
Right.
Okay, so
Okay.
kind of
Well, that
going
makes
back to the
sense.
higher amount, sub Q it absorbs into the body slower. There's not as
Slower.
much
Yeah.
vasculature to grab the oil that we secrete into
Hmm.
that space versus if we did it into the muscle, it doesn't enter into the body as quickly, and we don't get that spike.
Yeah.
Okay, so that was what that study was,
Why
and
didn't they
it did show
use
that.
test sip in both of them?
It's a great question.
Like, why would they use two different? Uh,
Well, let's just put it this way. There happens to be a certain auto injector that is now
oh, there
branded
we
that is testosterone enanthate.
go. Mm,
So we happen to know that, that wouldn't be a study or anything to show that it's better to use than
that's funny how that
testosterone
works.
cypionate.
Oh God.
For those of you listening, we're talking
Always,
about Zyosted.
always comes down to the same thing every time.
Yep. So there you
God
go.
damn it. So, yeah, you know what? That makes sense though about the sub Q
Hmm.
that it would because it absorbs slower.
Right.
Huh.
The thing with sub Q, I don't have problems with people that want to do sub Q versus IM. I mean, it's totally fine to do it that way. I I personally, and there's no written rule for this or anything, I don't like guys to inject more than 30 units sub Q.
Oh, right, right. Yeah.
Only
Well,
only testosterone, and it's because it's an oil prep, right?
yeah.
Because
Well,
then you get these balls
that's exactly it. I get
yeah,
those guys all the time to say like it's like it's balled up in there and it's like two
yeah,
days and then it goes away and
right.
yeah.
So that's just kind of like my rule that I have. I don't like oil subcutaneous injections to exceed 30 units. Now, like non-oil prep, like sterile, sterile water solution prep
Hmm.
stuff. Yeah, dude, you can dump all that in you want. It's going to go in no matter what. Just go right
Right.
into the
Hmm.
subcutaneous fat. But the oil does not disperse like that. So, peptide wise, like the epitalon that I ran for what it was a full cc into the belly, which is kind of a lot
Yeah.
into the subcutaneous fat, but it's fine, goes right in.
Huh.
So
Yeah. So I guess if you did sub Q, you would have to do, if you were doing that much. Yeah. If you were doing like 100, like that's what mine is 30 units 3 times a week.
are you
So,
back at 180 right now?
no, 150, right? Yeah,
Yes, the
150.
25 would be what you do for
Oh,
150.
25. Yeah. 25 units. That's right. That's what I hate. That's I do. I'm doing all this other shit. The HCG, I got it's 15. This one's 20.
I get
Yeah.
it.
Right. So 25. Um, yeah. So if you did, uh, well, 25, I guess would be okay, right? Or is that
25 would be
still
okay. Yeah.
okay?
Nope, it'd be fine.
So if you were at 180, then would you have to inject more, like you would do 4 times, like basically every other
Like if you
day?
were 180 and you were just injecting twice a week, then you'd be injecting what 40 units subcutaneous. So I wouldn't. You could. I just don't like it because then it just like that's a lot of oil to inject in like one spot subcutaneous.
Right. Right.
So I like keeping it at 30 or below because I find that at least then it does at least get in somewhat
Mm.
quicker and it doesn't
Yeah, that
leave
makes
as
sense.
big of the knots, but that's kind of like my professional limit that I try to keep people under if they're going to go that route. If they're above that, then we may want to maybe extend it out or add another injection and just thin that out a little bit.
Yeah.
Instead of doing 80 twice a week, maybe go to 83 times a week.
Hmm.
I don't like doing that for people with super high SHBGs because I do need to bring that SHBG down via um, I do need to bring the SHBG down via androgen administration, and I do want it to come down. So, that might not be something that I do in somebody with a higher SHBG, giving
Yeah.
testosterone to it, just because, and I may not recommend the sub Q route at all to that person because it's just too slow,
Yeah.
to be absorbed. So they're just little nitpicky, little nuanced things.
Yeah. That's the thing. There's so many other things that go into, like you
Yeah.
try to lower it, but then, yeah, you have SHBG that you have to worry about.
I mean, you don't have to worry about it, but it's something that like if I've got a guy coming to me and he wants to feel the best that he wants to feel, and I'm going to try and get him to that spot, then we're going to work towards that. But
Yeah.
also I don't want somebody's SHBG to be 65. It's not a bad thing, so don't think anybody listening here that having an SHBG of 65 is terrible. It's not. It's actually way better than having an SHBG of like 10.
Lower, right? Yeah.
Yeah, lowers bad. Like
Hmm.
I don't like single digit lower, awful. 65, not bad at all. Probably tells me you're really healthy, actually. But it also tells me that it's going to be, we're going to have to bring it down a little bit to get a better androgen ratio, essentially.
Hmm.
Um, so we'll work on that, and definitely it will happen, but it just takes a little bit of time,
Yeah.
a little bit of finesse.
Well, I guess also, Josh, is hydration. I think people overlook the hydration part with the hematocrit.
They do, and you definitely can have some people that don't drink. I actually, I don't like any of my labs fasted. I'm not here trying to check, fasting insulin and that. We're not a functional medicine office. We're dealing with hormones. So I tell guys, hey, drink 16 to 32 ounces an hour before you come in. Just make
Yeah.
sure. I want to make sure you're hydrated. I don't want you to come in like after you just got off the job site and you haven't done anything and you're dripping sweat and
Yeah.
you have nothing in you and usually I can tell too, a lot of those guys, because they'll come in and like they'll have a red blood or a red blood cell count, like an RBC that's fairly normal, but their hemoglobin hematocrit's like really high.
Right.
And that's how
Right.
I'm like, all right, that doesn't make any sense. Like if your
Yeah.
RBC is like 5.25 and your hematocrit's like 18.5 and your hemoglobin's 18.5 and your hematocrit's like, you know, 56 or something like that. I'm like, yeah, did you
Yeah.
drink anything when you came in? And they're
No,
like,
I just put a
no.
roof on the last
Yeah.
for the last 9 hours.
It just doesn't match up.
Yeah.
So, those are some things you have to look at too. Um,
Okay. Yeah, I mean,
but
you just got to drink more water. I mean, all the time.
yeah, protocol modulation is probably the first thing that we would do after identifying causes. So that's always
Hmm.
number one. Identify cause, you know, lung disease, sleep apnea should always be number one that you're thinking about
Yeah.
for anybody, like even patients, not just clinicians. Like you as a patient going in should always be like, do I have sleep apnea? Is that a thing? If my hematocrit's high all the time, um, that should be something that, because testosterone can increase central sleep apnea when you first start. And so you have couple types. So you have central sleep apnea, which is when you just flat up stop breathing. Okay. Like it's a central issue. Your brain's
Jesus.
like, no more breathing, and you just stop doing it. And it does
Jesus.
increase the incidence of central sleep apnea within like the first 3 months of starting testosterone replacement therapy. But if you've got a guy with like a thick neck who probably has OSA or obstructive sleep apnea, which is like, the whole weight of his neck and his throat is like laying on him, and then you give him testosterone, now you're throwing potentially a central sleep apnea component on top of an obstructive sleep apnea component. You can make his sleep apnea really bad
Jeez.
for a period of time. It doesn't last, but these are things that you have to be like, okay.
So if someone does have sleep, I mean, do you still start them on TRT, or is there ever a time where you don't?
If No, if somebody has sleep apnea, they're generally going to be mitigated already, meaning they're going to have a CPAP or something. If
Hmm.
they've come and they've told me that they have that, I've had people come and say, well, I've been told I have sleep apnea, but it wasn't bad enough that I needed to do any intervention at that point.
Okay.
Um, so obviously they make CPAPs. They even make BiPAPs, bilateral positive airway pressure, but continuous positive airway pressure is a CPAP. That's what CPAP stands for. Um, and they also make mandibular advancement devices. You see all those like snore mouth guards and stuff. All those are
Hmm.
mandibular advancement devices. They take your jaw and kind of push it forward a little bit.
Right.
So what that does is it pulls your soft palate, it pulls your tongue uh, up from the back of your throat, so it doesn't block off that airway.
Okay.
That's all that they do. I have one of those. Matter of fact, I think I might have it. Nope, it's not down here. I think I have upstairs. I hate it.
Oh yeah.
It hurts my jaw. Like
Oh,
I'll
it
wake up.
does?
Yeah, it does. And I wake up and my jaw's like really sore. And it's funny because it's really only moved forward by like a couple millimeters, but it's just that much.
Really?
You just wake up and you're like, oh yeah, your masseter muscles, which are like right here in your jaw, they're just killing you. You're like, oh,
Damn.
so
Yeah,
I
so
can't wear it.
so there are guys that you can have sleep apnea and obviously start TRT, but it has to be managed, the sleep apnea.
If it's worse enough to be managed, it's going to be managed if you've been told that it needs to.
Okay.
So it's usually going to be done before you start. And I'm fine. If you have managed sleep apnea, you're not going to have issues with your hematocrit.
Right.
So
Right.
from the sleep apnea, because it's been taken care of. It's
Okay.
the same thing like when I have a guy that comes in and he's like, yeah, I have heart problems. I had 2 stents placed. I'm like, well, how long was that? Oh, about a year ago. I'm like, great, that's awesome. Because you've been cathed within the past year. You had 2 blockages that are now taken care of, right? We know all the other blockages you have because you had the cath done. Perfect. You know what I mean? Now,
Yeah.
now we know what we're getting ourselves into.
Right.
You're getting, and
Right.
we're going to just work on improvement.
Sure.
And we know we're not going to have like hopefully any crazy events because you just had them taken care of.
Yeah. No,
So
that's actually not a bad start. It's
yeah,
like, you know what I mean? You get everything cleaned out and ready to rock.
right, exactly. So you've already had your diagnostics done. You've had your heart cath. You already know the narrowings on all the arteries that are there. The bad ones have been mitigated
Mm.
and taken care of. They're stented. Now that's not to say that it's like all hunky dory, but you're in a much better spot than if you just didn't even know
Then the
anything
other,
was
right.
happening
Yeah.
and you
No,
go
for
on
sure.
testosterone and you have a heart attack 3 months later and then they blame
Oof.
it on the testosterone
Yeah.
when in reality it was probably just a time bomb waiting to happen anyway.
Yeah. That's no good.
So I love when I get guys that are like, yeah, I just had a heart cath. I'm like, come on over.
Yeah. So everything they're
So
all cleaned out, ready to go.
yeah, they got a brand new lease on life. Let's keep it rolling. You know what I
Yeah.
mean? Let's give you even better metrics down the road.
So,
So
all right. I mean, I guess donating blood, if, I mean, that's like worst case scenario. That's like, that's what it should
yeah,
be.
and
We're
I'm not
thinking
really
of it.
aggressive on blood donations because again, it doesn't solve the problem
Right.
of the underlying cause. It's just a temporary band-aid. Does that mean that I have not had guys go donate? I have had people donate blood on 2 occasions. And both of these were transfer patients in that were on some really crazy protocols.
Mm.
And I didn't want to be like the person to put my name on there when like their hematocrit's coming back at 60. You
Yeah,
know what I mean? Which
that
is like
makes
through
sense.
the roof. And I'm like, yeah, we're going to start fresh, but we're going to like get this slate clean before I even get
Yeah,
involved
we're gonna have to
because
bleed you,
yeah,
start you,
because I'm like, this is nuts.
get
Like
the
that's
demons
even
out of you.
yeah, get the demons out of you. I mean, I'm pretty liberal when it comes to uh hemoglobin hematocrit. I've routinely have people at 54, 55, and even a couple people at 56, and they do not donate blood and they are perfectly fine. Um, but you know, 58, 59, 60, we're
Start
getting
getting,
into
yeah,
the okay,
yeah.
we gotta
I
take
mean,
care of
that's
that.
like that's what scares a lot of the people, is the stroke stuff. You know what I
Well, the
mean? Like
thing here
that's,
is if you read the literature that exists, the the issue you have here is it's uh, increased hemoglobin hematocrit is called secondary erythrocytosis from testosterone, secondary to the testosterone. Okay, um, when you have just the increase in red blood cells, it's just red blood cells. It's not clotting factors. It's not platelet count. You know, none of that goes up. All that stays the same. Okay, it's just your red blood cells. Um, And there's really no published literature, to my knowledge, that having just increased red blood cells leads to an increased risk of stroke.
mm,
Now, polycythemia vera, yes, there's literature on that. Absolutely. Okay. Which is an increase in all of those cells. Because if I just increase your red blood cells, but I don't increase your platelets in turn, you're no more risk of forming a clot because you don't have any more platelets than what you would have had normally.
right.
Right.
Okay.
You don't have any more clotting factors in your blood
Hmm.
than what you would have had normally. You
Yeah.
just have increased, you know, yeah, sure, the viscosity increases, but it doesn't necessarily mean that like your blood's going to form a clot either.
Right.
So,
Yeah. That's just, I mean, it's the same thing. You Google it and, or somebody at the gym or whatever it is. That's
mhm.
a fear that everyone has.
Well, again, you know, there's a lot of clinics out there that I don't really feel like a lot of people are getting great medical evaluations.
Hmm.
Unfortunately, you know, it's I think it's a keen to this industry, not just this industry, but other ones too. And, you know, there's obviously a lot of people just trying to get their hat in the ring for the quick buck and
Yeah.
any way possible. And, you know, unfortunately, I think things get missed because they're not in it for the right reason. They're in it for their reason, maybe not the right reason for the person that's coming to you, but, um, you know, and so stuff gets missed. And that's when problems happen. And I think that ultimately does a disservice to the industry as a whole.
You're
Um,
sure.
you know, and it makes everybody look bad, even though
Hmm.
that you know very few places, you know, the good places aren't doing that type of stuff. It only takes one bad apple to make the whole bunch look terrible,
That's how,
unfortunately.
unfortunately, how it works.
Yep.
Just
So
one, and then they have a YouTube channel or they have a TikTok and they start talking, and then
yep,
that's when everyone starts listening.
yep.
Yeah, I knew this
So
guy and he had a stroke. You're like, son of a bitch,
yeah,
so
that's how it is. So you have to,
yep.
you know, there has to be a little bit of defensive medicine in this with some things, and certainly we're vigilant about that. We're aware of it. It doesn't mean that you know we're not trying to help people. We absolutely are, but at the same time, you know, we do live in America. It's very litigious,
Hmm.
you know, and I can present everything under the sun, but until something bad happens, somebody's looking for something, you
Yeah,
know, and
exactly.
so you have to be careful, but you also have to be educated, and you have to be on the top of your bar, and you have to be, you know, vigilant and screening for some of these things
Yeah,
and do it. So I'm not trying to say like you know every place is bad. That's not what I'm saying. I'm just saying that some of them may not go through all the proper steps that they could be doing. Maybe taking a little bit easy on some of that stuff. So
okay. Well, I think the summarize today would be you have to eat healthy,
yep,
you have to work out,
to work out.
um, try to change your lifestyle to make it a healthy lifestyle.
Yep.
I'm going to drink, a lot of water,
Eat less
um,
salt.
eat less salt, and if you have to donate blood just because you want to, then you should, but
Yep.
only a couple. Oh, you know what? Here's a question. What about so if you are say like, I get blood work done every 3 months, right? For you.
Hmm.
If I was going to do it, I mean, I'm not going to, but if I was, how would you schedule that in? Does it matter? Like in between the 3 months, if I was to donate blood, would it do anything?
So the idea is if we're gonna have you donate blood, we're gonna have to check blood afterwards anyway, because I need to know what your hemoglobin hematocrit was at and where I want it to be.
Mm,
Right. So we have to get another hemoglobin hematocrit to see where it landed after the donation. But
mm,
that's generally the only lab that you would need post donation.
okay.
So
All right. Well, so if I'm just saying,
if
if there is guys that are out there that want to donate, it gets,
if you want to donate just for the good of your heart, you don't really need to have those labs checked afterwards at all.
oh, okay.
Yeah, you could just go donate and be done. Like,
And just roll.
I'm talking more of a therapeutic phlebotomy where like you have to
Oh,
like your
right.
hematocrit's really high and like
Yeah.
I want it to get to a certain point
Oh,
and I
okay.
need to
Okay.
know it gets to a certain
Yeah.
point.
I was saying the guys that just want to donate
Oh
for,
no, if you want to
their own.
donate for like just being a
Okay.
good person and doing like a
But
blood drive or
will
whatever,
that
and just
affect the bloods? Like, say I did it a month and a half in, and then a
yeah,
month and a
so
half later.
just let the provider that you have know that you donated blood.
Okay. So it will have
Yeah.
some kind of
Oh,
effect.
it'll show up. Like I've actually had that happen where I've had a guy, um, great patient. All my patients are great. Speaking like Trump right now. I've got
They're
the greatest patients
beautiful.
in the
They're the
world.
most
They're
beautiful
beautiful.
patients.
They're the most wonderful patients ever.
They
Only
all
I
hate
could have the most
China.
wonderful. Yeah. um, but at any rate, I started him on testosterone, and he comes back first follow up, and his hemoglobin hematocrit's lower than when he started. And I'm like, "Do you
Lower.
donate some blood?" And he's like, "Yeah." And I'm like, "When were you going to bring that up?"
Oh wow! Now that you say it, like it's like,
I was
jeez.
like, why'd you donate it? He was like, well, a friend of mine told me that like you needed to when you went on this stuff. And I'm like,
Oh
you realize you
jeez.
could have just called me.
Yeah. That's.
He's
I
like,
mean, that's what it is. That's what happens.
yeah. And I'm like, you realize you could have just called me and I would have told you what you really needed to do. And
Yeah.
like, don't donate anymore.
I
Cause
mean,
he
because
felt
I
horrible.
get
He felt,
messages
he's like,
from people that are like, I don't want to get on TRT because, it's a lifelong commitment, or and then they'll say, and I don't want to donate blood, and I don't want to lose my hair, and I'm like, well, two of the three, I think we can that aren't really like
yeah.
something you have to worry about. I'm like, but
The lifelong commitment thing, I kind of get irritated by that. And I'll tell you why. Like people are like, I don't want to do it because it's a lifelong commitment. Do you know what that tells me? It that your symptoms aren't bad enough, that you don't
right,
care enough, right?
yeah,
Like you're almost looking at it like an option rather than like, you
yes,
know, like you haven't got your symptoms haven't gotten worse enough to where
hmm
like you really care to make them better. Because if you did, you would not care if it's lifelong.
I it's a nurse practitioner on TikTok. Um, I'm not even going to say if it was a, I already did, but shit. She posted something. It's a small little clinic somewhere. It came up on my thing. And she talked about how when she's had clients that come off and people are afraid that it's going to drop down to, their levels back down. And some of the guys, it didn't drop as much and that they were able to. And I wrote, well, why would people want to come off? Like once people are on, I've never heard of anyone that wants to come off
Right.
like that, like, and she goes, well, there are people that do, like they don't experience, she goes, they don't experience all of the benefits of it and they don't think it's worth it. And I just wrote back, I'm like, maybe their provider isn't doing a good job.
Wow.
And I didn't mean like, I I just wrote that and saying like as
Yeah,
if I was talking to
you weren't
her. I
right. You
didn't
weren't
mean
necessarily saying it was
after I
her.
wrote it and sent it, I was like, oh shit, that's like that came out wrong. Like it's like it was just and she just didn't respond. And I was like, yeah, that's my bad. Like I didn't, whatever. But I
So
didn't
small
mean it.
town NP person, if you're reading this,
Yeah, I didn't mean it like
TRT
person. I'm
dad
just
is
saying
sorry.
that, maybe the provider wasn't, I'm not saying it. I mean, all right, let's be honest. If people aren't doing it, it's because you're doing it wrong. Like if
Yeah.
people want to come off for whatever reason, then,
To date, I have not had one person come to their 6-month follow-up and be like, I want to come off this. Not one
yeah,
person has told me that yet.
yeah, like I don't feel better.
I've had people come off and leave my service, but not for that reason.
Yeah. Yeah. I mean, you're always going to have like money or whatever
Yeah, that's honestly
people.
that's the number one
Yeah.
reason. And I think that's number one for pretty much everywhere.
Yeah. I agree with that. But there's no way you go from and here's the thing, if you actually have low T symptoms,
Hmm.
that, you know what I mean? I think there is group of people, small group of people that jump on this thinking that it's like, I'm going to get in shape. You know what I
Yeah.
mean? And it's like they think it's like the quick fix to something. It's like, well, you didn't necessarily have low T symptoms. You just needed to go to the gym
Well,
or
and
you,
see, that's the thing that we focus on. If you don't have any symptoms, like even if you do have, let's say, lower testosterone, let's say it's like 400, 450, but you don't have any symptoms, you don't necessarily need testosterone.
right.
Because I mean, what is me giving you more testosterone necessarily going to fix?
Yeah, exactly.
Do you know what I mean? Like the whole idea is like if you are hypogonadal and you have hypogonadal symptoms, then testosterone will fix those symptoms. But if let's say you are like 450 and total and you don't have any symptoms, me giving you that testosterone isn't going to magically just be like you're gonna be like I don't feel
Yeah.
really much different, you know.
Yeah, I just had a
Um,
guy message me the other day. He was like in his 50s or early 60s. Might have been his early 60s. And he said that his total was like 530 or something, 540, something like that.
okay.
And he was like, but everyone's telling me that it's low and I should go. And I was like, I go, listen, I was like, I know everyone gets hyper focused on the numbers, but like, just how do you feel?
Yeah, that
Like, do
should
you
be
feel
number
good?
one. How do
And he
you
was
feel?
like, honestly, he's like, I do feel good. He's like, but I'm just thinking, like, can I feel better? I'm like, well, you probably can, but like, if I was in your shoes and I felt good, I don't know if I would do it until I
Right.
felt like I feel like shit. It's
Right. Or
like
you
that.
have like erectile issues
Yeah, right,
or and there's even a case basis to say like I have um issues like cardiologists will put people on it because their heart's not great,
right, right.
and they'll help to increase the endothelial compliance and everything with that. So
Mm,
there's maybe a reason for that. Maybe they aren't necessarily hypogonadal in terms of like our typical sense. They're tired, they've got low libido, this, that, and the other. But maybe some other medical reasons that we could indicate that
sure.
for. You know, bone density.
Mm,
Those types of things. But I mean, those are going to be very few and far between, and not typically like your walking well population. So,
right. Yeah, that makes sense.
but
Well, yeah.
yeah.
I think too many people get focused on the numbers, and
They
it's like
do.
just take a step back. How do you feel? You feel good? That's
Mhm.
all you got to go off. Well, should I inject 2 times a week? How many do you inject now? I inject 1 time. How do you feel? I feel
Mhm.
tired 2 days before. Switch it to injections.
Yeah, I mean, I don't have anybody on once a week injections, but I've heard,
Yeah,
when I was in the urology group, I had people doing once a week injection, and some people do okay with that.
there's a lot of guys that talk and say that I feel I'm perfectly normal.
Yeah, and I'm
I'm
like,
like,
you know what? I'm not here to tell you to not do that. You know
right?
what I mean? Like if it's working for you and your labs are okay and you feel great,
Yeah,
what am I, adding that extra injection
yeah.
isn't necessarily going to change anything for
It's
you.
exactly it. They go off
So,
of the feel. None of this.
yep.
Can't get too caught up in numbers.
Yeah,
How
and
do you feel?
I don't, like I said, I don't recommend one injection per week at my clinic. We
Hmm.
always minimum of two, and that tends to be fine. We get a lot better results. But again, people that have done the one in the past and they're great,
Yeah,
stay at it.
yeah. It's not a lot of guys, but there are
It's not.
some.
Yep.
But the majority seem to do good with 2. And then there's
Mhm.
like, and then it jumps. There's only like a few of the threes. There's only like I'm a small group of guys that are in the threes.
Well,
There's the
I'm in the three
twos.
too.
Yeah, so our group is small. And
Yeah.
there's because I've noticed it's the ones and then it's the daily sub Q guys. Those are the ones that just fight amongst each other. Like,
The daily
I
sub
mean,
Q
not the
guys.
ones. I mean, the two injections a week are the
Uh,
popular ones, and then the daily sub Q ones. They're the two that just fight amongst each other about which is better. And then like the threes and the ones are just like, yeah, I'm good, dude. I'm
I'm
out.
good.
Like,
I'm out.
I'm cool. I got to go to the gym. So, all right, Josh. Well, I think we answered a lot of questions for everyone. And obviously, if they have any more questions, they know where to find us.
Yes.
Um, but we will be back next week. Come
Yeah.
up with
Oh,
some.
I do have some people lined up for some guest speakers on the podcast.
Oh, nice.
So in the coming weeks, we will get them. It may even be next week that we could do one of them. Um,
I have
we're,
one next weekend with a guy from Ethiopia.
oh, wow. That'd be great.
Yeah, dude. When he reached out to me, he
That's
was like,
awesome.
can I come on the podcast talk about TRT?" I was like, "Yeah, man, sure." He was like, "Yeah, I'm from
I think that's
Ethiopia."
really
I'm
good.
like, "Really?" He was like, "Yeah."
Still living there?
I guess it's what he said. He's like, "I'm from Ethiopia." Oh, he said, well, I don't know. I mean, he said he was from Ethiopia. I should look into it more.
Yeah, I don't know if he's still living there or just he was from there but lives here now, you
Yeah,
know.
yeah. Son of a
Um,
bitch. I gotta look into this now.
yeah, it's good. We want to
Yeah.
get, that'd be good if we need to get somebody from that continent.
That's
You
what
know
I
what I
want to
mean?
do. I was like,
Yep.
yeah, I went across the pond, went north. Now
Yep.
we go to Africa.
And I'm still doing my, consultations for international clients. So we do, I think I'm up to 4 continents now. So,
Nice.
yep.
There you go.
I really like doing those. They're very enjoyable and the men find them very valuable.
I had the guy from Australia and then it just faded out. Just stopped.
Yeah.
We were communicating and then I probably found
So the
another
people
TRT.
the topics that we can discuss here in the future, just to kind of give people some preps. I think I'm going to have Mick on to talk about testosterone in the aging male. So these are going to be like guys that are like 60, 70 plus.
Okay.
Okay. Going on testosterone, maybe at that time, maybe, because they're that age now, there's no barrier to that, but he does a really good job in that particular aspect, that realm of care. And I think that'll be good. I don't really obviously know our average viewer age, but just because you're 70 years old doesn't mean that you can't go on testosterone,
Sure. Yeah.
um, or 80 years old, that's totally okay. And I
Hmm.
think he'll do a really good job explaining kind of that. So we'll get him on. And then I'm going to have Trevor on, and Trevor's going to talk about uh, testosterone. And we'll also have Trevor talk about the P shot.
Oh,
So yeah, so we actually are starting those next week in our clinic.
are you
Uh,
dope? That
yep,
next week is it?
next week's that's it, brother. We're rocking and rolling. I got everything ready to roll. Pumps in hand, and
No shit.
yeah, I feel like Austin Powers. Not mine.
Do you have to pump when you do that too? Is that you
You
have to do
you
that?
do you do afterwards. Yes.
Okay.
Yeah. Yeah. Not forever, but for like 6 weeks. It's part of the program.
Oh no shit. You have to do 6 weeks. You have to do it.
Yeah.
How long?
Twice a day for like
Oh
5 minutes. Yeah.
oh
It's
okay.
just, it's to help get more blood flow in. I mean, if we're going to put plasma that has all this stuff in it, we want to like we were talking about earlier, you need blood flow, and that's
Yeah.
what's going to help get more blood flow in and help
Hmm.
the plasma do its thing. So, yep. So
Cool.
you get a Swedish made penis pump.
No shit.
It's actually not Swedish made, but yes, you do get one.
Couldn't find any made in America. They didn't have any made in
I
America.
bought it from
Assembled in
California, but
America.
I don't think I don't know. It came from somewhere in America, but
That's what
it's
most of it.
probably
It's assembled in America.
yeah.
I'm like, that means it's made in China.
It's
That's what
gonna
the
be
fuck
it's
that
gonna, I
means.
can tell you one thing. It's gonna be used in America.
Yeah, for sure. Everything's used in America.
So, but he'll be able to. When we have him on as a guest speaker, I think it'll be really good. He's been doing P shots for maybe not quite 2 years, but he's done a bunch of them. So he'll be able to give a lot of good feedback.
Hmm.
If you have questions on that, beyond what I can answer, um, situations, and I'm sure I'll be asking him some stuff he can talk. I think that'll be a good one.
Yeah.
Uh, we'll
Yeah,
really
maybe
enjoy
we'll
that one.
open that up to the people.
Yeah,
They can
I think they'll really like that. So,
yeah.
and then I have we'll probably get Mason and then Evan. I've got a bunch of people that reached out that want to come on and chat. So I think we'll slowly integrate them on periodically over the next couple months.
Yeah. I've been
So
asked people asked me to have the hacksmith back on.
nice.
So I said, all right, well, we gotta go through. We'll give him some time. I mean, he's busy. He's got a very busy schedule.
Yeah. Well, that too, and I think it's one of those things that that peptide space is. I mean, what you just did his thing on isn't necessarily going to change in like 2 weeks.
No, no,
You know what I mean?
exactly. Yeah,
So
exactly.
you got to give it some time to kind of build
Yeah,
back up
because there
again to
is
where
like, yeah,
the
he did talk
information's a little
about some
different.
other ones coming out, and I said, maybe that's what we even said. Maybe when Retatrutide dies down and the
Yeah.
next one pops up.
I think SLU PP332 is going to be probably the next big one that gets talked about. So
What does that
um,
do?
that's
The,
the estrogen related receptor antagonist.
hmm
So increases fatty acid oxidation, increases mitochondrial efficiency. There's no human studies on it yet,
mm.
but the animal studies show significant fat loss and body mass reduction through fat
Oh,
loss
yeah. He
because of
he
that.
mentioned something that was going to be, I guess it's similar to Retatrutide, but also is like helps with building muscle as well. So it's kind of like a
Oh, they're doing a couple trials right now with, I want to say some of the myostatin inhibitors with GLPs.
oh, okay.
Okay. I don't really think they're going to be the saving grace that a lot of people think they are,
Oh,
unfortunately.
okay.
So, because I've been seeing them pop up periodically, uh, with these myostatin inhibitors or giving follistatin, basically is sort of a way because myostatin is basically your body's check valve for how quickly you can grow muscle.
Oh,
Um,
right.
did you ever see the myostatin knockout mice or the myostatin knockout cattle? It's
No,
like you're it's like the cow. It's a real animal. It's like the cow that looks like it's got like muscles on top of muscles. It's just like that jacked cow.
no, I've never seen
Have you
that.
ever seen that? Yeah,
No.
just Google. It's called the myostatin knockout. Uh, myostatin knockout cow, and then there it is. There's a picture of it there, and it's just this cow that is just freaking jacked. I mean, it looks like it looks like a gym bro cow.
Yeah.
um, but it has myostatin gene knocked out, so it has no inhibition to how quickly the muscle can grow.
Oh,
Okay, so it's just this massive monstrosity of muscle.
no
Um,
shit.
so they're trying to, I think the thing is to combat the lean muscle mass with GLPs. They're trying to get creative and saying like, well, maybe if we can inhibit myostatin,
Right,
the
right.
muscle won't
Hmm.
we won't lose it.
Yeah.
But I don't think it's going to be as potent as what people think it's going to be. I'll just put
Hmm.
it that way.
Okay.
So the
Wait
other
and
thing is
see.
we don't really know any long-term
Right, that's the other thing.
effects of myostatin. And that's one I think from a plausibility standpoint, kind of I would be very hesitant to get into that space, right?
Yeah.
Because if you grow muscle mass incredibly fast, right? If you like get rid of myostatin completely, I believe Flex Wheeler had something. The bodybuilder Flex Wheeler had something with myostatin and his some issue with that, and that's how he was able to get so big. But um, my thing would be like if we start messing around with this and we put on muscle incredibly quick, what type of strain is that going to have on our heart?
Sure.
You know what I
Right.
mean? By adding that much tissues that quick,
Quickly. Yeah.
right? And that's the thing. It's one thing if you do it over a span of time where the body can adjust, but if you do it so fast,
Yeah.
and that's sort of like my major concern when I look into like that type of space. So
Yeah. Yeah, I don't know. I mean, it's going to be a wait and see, I think, with a lot of this stuff.
yeah,
We don't
yep,
really know exactly, but so I'm still hesitant about people that lose absorbent, like just 100, 200 pounds in like a very short amount of time.
yeah.
And I'm like, man, I don't know. I mean, I guess it's good for you to do that, but is it though? Like, is it,
200. I think it all depends on how big you were when you started.
Yeah.
If you were 500 pounds and you lost 200 pounds, you're still 300 pounds.
Yeah, that's true.
But if you're 250 and I mean, you can't really lose 200
Y-
pounds. You'd be 50
Yeah.
pounds.
Pretty
So
low as 100 pounds,
yeah, I
you
mean,
know?
150. I mean, that'd be too much.
Yeah.
Depending on how big you would be. So I think it really just depends on where you start and where you finish. Um,
Yeah, I
but
guess we'll wait and see,
wait and see.
like everything else. All right, Josh. That's it. So we have, I think we covered everything and more.
I think so too.
All right.
Cool.
I have to go set up for my daughter's 11th birthday party, the girls' sleepover. So
Please enjoy.
yeah, it'll be fun. Set up little teepees or whatever the hell
Woo!
it's. Oh no, princess tents. I
Princess
forbid.
tense.
Can't say
Oh.
teepees.
Hey, you only turn 11 once.
Right. Yeah. Well, this is like a month-long thing. So all right, Josh. I'll talk to you later.
All right, brother.
See ya.
See ya.